Hello, everyone, and welcome back to another week of Epidemic of Injustice. As always, please take a moment to introduce yourself in the chat with your name and pronouns. Please check in if you did not already do so in the waiting room using either this link or the code on the screen. As always, you are muted upon entry and you will not be able to unmute yourself until the discussion portion at the end, but please feel free to put your questions and comments in the chat throughout the presentation, and there will be time for questions at the end. And before we begin, we just want to take a moment to acknowledge the events that are happening in Ukraine right now. We always want to draw attention to the injustices that are happening in the world, and this is no exception. So we recognize that you might be feeling stressed or anxious during this period. So please take time to take care of yourself if that's what you need. And now, Wendy, I will pass it over to you.
Thank you, Zoe. So just as always, a reminder of the Zoom participant controls. You were muted upon entry. And we can go to the next slide. And these are the instructors for the course. If you need to reach out to any of us during the class, just go ahead and send us a chat directly. And for anyone who may be new to the course, just to give you a little bit of background, the class was created because of student leadership in radical public health, and now it's sponsored by the Collaboratory, where we are trying to bring community voices to the forefront across the School of Public Health. You can find more information about the course and also the Collaboratory on their website. Just to remind you all, we do have community guidelines that we want to adhere to throughout the class, and that's listening with an open mind, having mutual respect and appreciation for one another, respecting the privacy and personal information shared in this space, just allowing everyone to participate, and as a no disruptive and disrespectful language will not be tolerated and will result in the removal from the class session. We also understand that today's lecture can contain material that might be difficult to discuss, so please feel free to step away if you need to take care of yourself during the presentation. We completely understand. And just to give you the land acknowledgement, the University of Illinois at Chicago stands on the original homelands of the Miami Three Fires people, the Ojibwe, Ottawa, Potawatomi, who have been stewards of this land for generations. Illinois is also home to a diverse Native community of more than 75,000 tribal members, many of whom live in the Chicago area. For those who are not currently residing in the Chicago area, we encourage you to look into the Indigenous people of your own lands. And for today, I am very excited to introduce Harriet Brown, who's a professor of magazine news and digital journalist at the SI Newhouse School of Public Communications and a sought-after speaker on college campuses around the country. She has written for the New York Times Science section, the New York Times Magazine, Psychology Today, Scientific American, and other publications. And in 2011, she won the University of Iowa's John F. Murray Prize in Strategic Communications for the Public Good for her work as an advocate for those with eating disorders. Harriet, thank you so much for being here, and I'll go ahead and turn it over to you.
It's my pleasure to be here. Thanks, everyone. I'm going to share my screen and then pull up my presentation, and we will get started. So can everyone see that? Give me a thumbs up or something. Okay, great. So I am here to talk about fat liberation. And the first thing I want to mention is a little bit about the word fat and the words that you will hear me use during this presentation. I use the word fat because to me it is a descriptor. It is neutral. It's a description of a substance that we all have on our bodies. And as such, obviously it has connotations in our culture. So a lot depends on what you bring to it and what you hear when you hear the word. But I, like many other people who work in this space, prefer the word fat to words like, for example, overweight, which contains within itself a judgment, right? If you're overweight, you're over the weight you're supposed to be. And far prefer it to the word obese or obesity, which you'll see me use in air quotes a lot, because that has become a clinical diagnosis, although the word itself simply means you have eaten until you've gotten fat. But it so much has sort of grown up around that word today, and it has become weaponized in a sense. So many people in this community choose not to use it. I think, as with everything else, each person should have the right to use the words that speak to them. And but I wanted to explain to you where I'm coming from with using that word. I recognize too that it might feel shocking to some people. I know that when I teach a course at Syracuse called Fat and Feminism, and I've had students tell me like I could barely look at the name of the course in the catalog. You know, it was really hard for me to sign up for it given the name. So I wanted to start with, what is fat liberation? And this is the best definition that I've seen from Lindley Ashline on the NAFA blog, the National Association for the Advancement of Fat Americans. And she says, fat liberation is the deliberate work of tearing down the systems that have created a world where fat people are denied full participation in society and life, from apparel to healthcare, right? Because I know that the term fat acceptance, fat liberation, a lot of those terms have come to be vilified and misidentified. So I think it's important that we get clear about what we're talking about. So how is fat liberation different from body positivity, which is a term that we hear much more often, right? So the crucial difference is fat liberation centers fat bodies and the lived experience of people in those larger bodies. Within it, it contains the notion that it intersects with other systems of oppression like racism and misogyny, homophobia, whereas body positivity typically centers the experience of thinner white bodies, and it's often discussed as part of the wellness industries, right? It's something we hear about a lot in magazines, online, and, it's come to have a pretty terrible rap in this community because body positivity can be anything from genuine fat liberation to, a thin white influencer crowing on their Instagram account about how they ate a donut and the world didn't come to an end. So that's a pretty big spectrum. We're clearly at the other end of the spectrum from that. So I want to talk about some of those systems of oppression. And the first one I want to talk about is media. And I, of course, am a member of the media as I write for magazines and I teach magazine news and digital journalism. So I'm painfully familiar with this. And clearly in media, there are, many, many representations, many perceptions that are created and, perpetuated of, cultural norms, what people should look like. And I'm sure we can all think of a million of those. But I chose this one in particular, the so-called headless fatties, for a variety of reasons. One, because it's very overt, and two, because it's ubiquitous. So the term headless fatties was coined by a sociologist in the UK named Charlotte Cooper. In fact, she's coined a lot of terms, a very interesting person, and she named it, although she didn't create this, and this is, these images that typically, go along with media stories about the obesity epidemic or, the childhood obesity epidemic, or we're all killing ourselves, or, fill in the blank. They're often very sensationalized stories. They're often full of overblown rhetoric. And they're often accompanied by these images of people in large bodies, typically with no face showing, often in positions that are demeaning or provocative. I did include one, often eating or, they're often eating ice cream or other foods that, would attract a lot of judgment in a public setting for a person in a larger body to be eating. The image on the bottom left, for example, was part of a whole ad campaign put on by this billboard company, right? They were trying to sell space on their billboards. So this is the way they did it, basically by saying, if you bought an ad here, you wouldn't have to look at this disgusting fat body. That's the sort of premise here. Or the image on the bottom right, where a woman in ill-fitting clothing is wearing sweatpants that say gold digger, or the man on the top right who's sitting with his legs spread, in a position that suggests, laziness, not caring, almost a sort of exhibitionism. So none of these are flattering. They're meant not to be flattering. And the intention behind images like this is to reduce people in larger bodies to objects, right? To say These are not humans. You don't have to care about them. They are here. This picture is accompanying this news story as an object lesson in what you don't want to be, right? So headless fatties, once you become aware of these images, you see them everywhere. So, take a look next time you see a news story about, quote, obesity. Another system of oppression within this world is education. And I've included here, 2 examples. There are many, but the image on the left is what's known as a BMI report card, which we will definitely be talking a little bit more about. So this was something that became popular, I suppose, at the beginning of the 21st century, right? Around 2000, 2001, a lot of the rhetoric about the obesity epidemic really got ramped up, and, to the point where it sort of hit the legislative arena. And there was a lot of talk about, children are all going to die sooner than their parents. What can we do about this? And this concept was born to basically send home a report card about a kid's BMI in addition to their report card about their academic skills. So this is an example of one. I would say that about half of the states still have some version of this, despite the fact that there's no evidence suggesting that they are effective. And by effective, I mean effective in what they were intended to do, which is basically make kids thinner, right? Because that's the realm in which they grew up, and that was their intended purpose. Maybe parents don't know how fat their kids are. Maybe if they knew, they could do something about it. Hence the BMI report card. But not only are they not effective in that sense, but they also have been proven to be very destructive, right? So my students, for example, when we talk about BMI at length, and we just had that day in class this week, and the stories that come pouring out of them about, those days when they were weighed in a public place, in the gym, when their BMI was sort of shouted out, when kids were comparing BMIs, and so not only is there a lot of shame and blame associated with them, but for a lot of young people, these BMI report cards, along with like middle school health classes, are the catalysts and triggers for what become eating disorders or highly disordered patterns of eating that can persist for the rest of their lives. So BMI report cards are known to do a lot of damage, but they are still perpetuated. And then on the right, you just see an example of the kind of messaging that has also become ubiquitous in schools. It's public health messaging. And, on one level, you might say, well, what's wrong with this? It's true, like, sodas and energy drinks are probably not what kids should be drinking. I would agree with you. But when you institutionalize the messaging in this way, when it appears in schools and when it becomes sort of part of that larger system of, because schools are about teaching kids how to live as well as like how to read and write and do math, they become deeply entrenched in a kid's psyche, and this whole idea of forbidden, allowed, sets up this dichotomy of good foods, bad foods that, again, can lead to highly disordered eating/eating disorders. We're not going to really get into nutrition during this conversation, but I just wanted you to be aware that it was there. So the next realm we're going to talk about is medicine. And, on the left, we have the BMI chart, which I'm sure you're all familiar with. And on the right, we have a sort of visual depiction of that BMI chart. And these are ubiquitous. You see them in every doctor's office, anywhere. And they are used as a way of diagnosing health status. And in fact, they become your BMI status is part of your medical record. And whether you're aware of it or not. So for instance, I was very surprised at one point when I got medical records for seeing an orthopedic surgeon. I asked for the notes because I was getting a second opinion about something. And I was really surprised to see in my chart, in the report of my last visit, it had my BMI, although I had not been weighed. And I think it was estimated. And then there was a whole note about how patient has been offered nutritional counseling and advised on ways to lose weight, none of which happened. None of that conversation happened. But because insurance reimburses doctors for counseling by the system, I think these things have just become sort of predictable parts of the medical record, whether they happen or not. So, and that is definitely a realm where oppression has grown up around issues of weight. So I want to talk a little bit about BMI. What's wrong with BMI, right? So it is the way we define fatness now in the medical context, right? So that is literally the diagnosis, body mass index, which is, of course, just a ratio between height and weight. And as you may know, BMI was, as a formula, it was created by a mathematician in the 1830s, Adolphe Quetelet, and he came up with it as a way, he was going for, how can I express the proportions of the average person? Although by average person, of course, we are talking about the average white European man, because that's what he was, and that's what he was looking for a way to describe. It was never intended as a way to measure or even express individual health, right? It was a way to sort of look at the health of populations on a broad scale. And so he developed this in the 1830s, and then not much really happened with BMI for quite a while, until around the 1970s, when another researcher, Ansel Keys, who's probably best known for running what is called the semi-starvation experiment. And if you're not aware of that, I suggest you look it up. It's really, really fascinating, especially if you have any interest in weight, health, eating disorders. But Ansel Keys did a lot of research on weight and health. And in the 1970s, he used the BMI, but again, on a sort of population level. And he said, okay, it's somewhat useful in that way, but, and this is literally a quote from him, the characterization of persons in terms of desirable weight percentage has resulted in attributing to overweight some tendencies to ill health and death that are actually only related to age. So what he's saying here is that it's very easy to conflate issues of weight with age, because BMI, after all, doesn't account for any other confounding factors. It doesn't take into account, it did take into account gender when it began, but it no longer does. Doesn't look at age, doesn't look at muscle mass, doesn't look at a lot of things. So if you're simply looking at a straight mathematical formula, you're missing an awful lot. That is sort of one aspect of the way this system of oppression is enacted through medicine. Another is through, and I know I'm going sort of fast, and I know that we're going to have questions afterwards, so just jot down questions if you have them. Normally I do this sort of more interactively, but we're on Zoom, so we'll do it like this. So another way in which medicine becomes part of those systems of oppression is in, the weight loss or bariatric industries. The weight loss industries altogether, and that kind of includes like surgery, it includes pharmaceutical, it includes nutrition, counseling, all kinds of things. If you put them all together, they're worth more than $255 billion a year in the US, right? So that is a lot of money, and a lot of money is a very motivating factor. And I think one thing to know about when you're looking at the research on weight and health, and this is something I kind of discovered accidentally in a way when I first started looking at this research like back in 2010 and decided to sort of teach myself what does the research actually say. One of the things I realized was that the vast majority of people researching any of these techniques and any of this relationship between weight and health have huge conflicts of interest, right? They own bariatric surgery centers. They own, they sit on boards of big pharmaceutical companies that produce some of the major medications. So You know, the weight loss industries and medicine are inextricably connected at this point. And I think that's very important to bear in mind. For example, this is the kind of messaging that doctors might see at some point, especially if they've got an independent practice. You know, this comes from one of a number of blogs: how to build a high profit 7-figure bariatric surgery program while improving patient outcomes. Okay, I'm glad we have patient outcomes in there. But, you know, this is not unusual. This is very lucrative sort of subspecialty, and it's big money. So stigma within medicine. A lot has been said about it, a lot has been written about it. I thought I would offer you some statistics that kind of surprised me when I came across them. So there have been a number of people studying stigma in medical situations, and these are just a few of the findings. You know, so a third of nurses said they would prefer not to care for fat patients. A quarter said fat patients repulsed them. 69% of obese patients said they'd been stigmatized for their weight by doctors. Frankly, that number seems low to me. And, you know, 33% of doctors surveyed feel frustrated by their fat patients, which I can actually understand because they're in a situation where they're supposed to be, you know, telling patients what to do to improve health. And we really don't have any known ways to do that through addressing weight. So I can understand why that's frustrating. Some of the other consequences, though, that it turns out that doctors actually do a lot less health education with their fatter patients, right? They're more prone to throw a prescription at them, or, you know, something like that, not to take the time with them. Medical students report that, you know, derogatory humor directed at fat patients is acceptable. I've personally heard some kind of horrifying stories of that kind of humor. Dietitians who were presented with charts of, you know, fictional patients that were identical in every respect except for, you know, BMI would put you in the obese category or in the normal category, rated their diet and health status very, very differently depending on their BMI, which is important because what it suggests is, or what it sort of illuminates, is the kind of assumptions that we in the culture and also we in the medical field make about patients who are in larger bodies, right? There's a lot of assumptions made about how do you eat and whether you exercise and all that kind of thing. And those assumptions really matter. They matter because, for one thing, stigmatizing messages don't inspire positive change. In fact, they make people less likely to engage in positive health behaviors, which makes sense, right? If you've been, you know, laughed at, discriminated against, made to feel less than because of your body, you wind up hating your body. And when you hate something, you're not really inspired to make it better. You're not really inspired to love it or take care of it. So, and also some of the research of a guy named Peter Munig at the Mailman School of Public Health at Columbia. He was one of the first to really look at, you know, the fact that stigma and discrimination can actually cause a fair number of the health problems that we associate with obesity, which are things like type 2 diabetes and cardiovascular disease and things like that. You know, he sort of was the first to posit the pathway through which that might happen, which we'll look at in a minute in more detail. And one of the things he found that was fascinating to me was that, you know, if you take two people with very, you know, similar or identical BMIs and other measures of weight, but one is okay with themselves, right? And one is like desperate to lose weight. The desire to lose weight is associated with more weight-related health problems. You know, why this is, I can't tell you. I have some speculation, but, you know, again, we live in a culture where it is considered so terrible to be fat that with any adult who is fat, I think you need to assume that that person has been on at least one or two or perhaps 20 or 30 big diets, that they have engaged with, self-loathing and, very much with a desire to lose weight. So that basically means pretty much all fat people fall into that category. And if it's true that, that kind of self-loathing and dissatisfaction is associated with poorer health outcomes, that's a huge public health issue right there. We also know that the stress of weight stigma, along with the stress of other kinds of stigma, right? So we know that, like, not just being fat, but, being a person of color in this culture, being, non-binary or LGBTQ, those things are also associated with an increased risk of disease. And Munich, made this argument in a pretty interesting way, that stress of that stigma, it elevates cortisol levels, which is which is linked to, we don't know what's causal, but is linked to some of those poor health outcomes, including like all the cardiometabolic diseases. So there's good reason, I think, to think about weight stigma in the medical realm as part of a system of oppression. Not everybody does, though. So this is he's not alive anymore, but this was bioethicist Daniel Callahan, who made headlines back in 2013 by it was kind of his version of a modest proposal, except I think I know he was serious. He wasn't being satirical, and he said, actually, we don't need less weight stigma. We need more weight stigma. He called it stigmatization light. And he said if it was used carefully, it could be like a great inspiration for people to lose weight. And he kind of compared it to smoking, right? And he said that, stigma has helped cut rates of smoking in the US. Maybe it would work for fat people. Not only is there no actual evidence for this, but, I'm just trying to think about what it would be like if we applied that strategy to other issues that we consider social problems, like, homelessness or mental illness. If we could just stigmatize people out of these things, that would be incredibly effective. So unfortunately, although he was one of the more outspoken people, I think there are a lot of people, and I know that there are a lot of people in the medical fields who believe this, whether they will cop to it or not. And one of the problems with that is that kind of stigmatization, strategy is based and rooted in assumptions that are not true. For example, there's this assumption that, being fat is bad for your health, and that even moderate amounts of fatness take years off a person's life. And along came Catherine Flegel, an epidemiologist at the CDC. She's retired now, but and she did a couple of big meta-analyses, not getting rid of anything, like looking at everything, the millions and millions of data points, and consistently found this chart, right? This kind of U-shaped curve describing the relationship between BMI and mortality. So in the current thinking, right, where fatness is bad and the more fatness, the worse, you would expect to see a linear relationship. You would expect to see a line starting at the bottom leftish and sort of heading up toward the top rightish. But that's not what you see. You see this U-shaped curve, which finds the greatest association, the highest risk of premature mortality at the two ends of the spectrum, right? The underweight end and the severely overweight end. And it's interesting to me that we never talk about that underweight end. We only ever talk about the upper end. But nevertheless, you see that at the two ends, and then you see the lowest risk of premature mortality, of dying early, in the middle, which is, somewhere between about 24, 25 on the BMI chart and maybe about 30 to 32, right? And so 25 is the cutoff 25.1, you're no longer of normal weight. You're now considered overweight. So in other words, your lowest risk, just looking at these two factors, your lowest risk of dying early seems to be if you are in that overweight to mildly obese category, which is interesting. And there are a lot of theories and speculations about why this is. The truth is we don't really know, but it's not how the conventional wisdom goes, and it's not what most doctors seem to believe either. And so on top of this association that we have with BMI and mortality, we also tend to assume that there are health benefits to losing weight. In fact, a lot of the rhetoric around weight loss now, interestingly, says things like losing 5 to 10% of your body weight can improve your health dramatically, which doesn't actually come from anything scientific, and never accounts for the fact that if you do in fact lose weight, which isn't that hard for most people to lose weight in the short term, you've probably changed some health behaviors. So, we wind up conflating health behaviors with weight changes as well. So this was an interesting finding Tomiyama et al. Wanted to see, does intentional weight loss actually make you healthier? And so on a broad scale, again, not talking about individuals because individual health varies, right? And what's good for your health might not be what's good for my health. But found that intentional weight loss, minimally affects any of these sort of specific health biomarkers. And none of those changes seem to be directly correlated with weight changes, which is interesting. So what most people do is what we call weight cycling, right? Which means you lose weight and then you gain it back. And I apologize, my elderly cat is yelling in the background, and you might hear her and think, what kind of demented baby is in the background there? But it's my 19-year-old cat, and I really can't make her stop, so she will punctuate this lecture. So most people wind up doing what we call weight cycling, right? Which is losing weight, regaining it, losing it, regaining it. Every time you do that, lose and regain, about 2/3 of people wind up higher than they started. And it becomes harder to lose weight because you're basically resetting your metabolism every time you do that. But we've only really just started to look at what are the health effects of weight cycling. Because honestly, I've interviewed lots and lots of doctors in the last 15 years for various journalistic pieces I've done, and most of them say some version of this to me at some point. Well, even if you lose weight and regain it, at least you were thinner for a period of time, and that's a health benefit. Well, that's not actually based in science, because it turns out that loss and regain is not good for you. It adversely affects your cardiometabolic markers. It's associated with increased risk for cardiovascular disease and all-cause mortality. It makes people more susceptible to weight gain, right? So the thing that you were trying to fix, it actually exacerbates it. And I wanted to, and again, in looking through this research and these studies, I'm often struck by the language in which these findings are presented. And I wanted to just show you one example of one bit of language from one of those studies, which I think demonstrates the kind of fat phobia and weight stigma that's baked into them. So this is from Montani et al. 2015. Of particular concern is the emergence of evidence that some of the potentially negative health consequences of repeated dieting and weight cycling are more readily seen in people of normal body weight rather than in those who are overweight or obese. Now, I don't know what the researchers intended here, but what it sounds like is they're saying, oh no, this is terrible. This is really bad for people who are not fat. We should pay attention to this. Meanwhile, every fat person in America has been undergoing weight cycling to some level for many, many years, decades often, and we don't really care about them. Again, I'm not saying that's what the researchers believe, but that's certainly what this language conveys. What would fat liberation say about medical weight stigma? Well, I think fat liberation advocates would say something like this, right? Body size is not an accurate indication of health. What they're not saying is, hey, we should all sit around on the couch and eat bonbons all the time and forget exercising. Nobody wants to do that. Like, that's definitely not. It's just saying you cannot tell my health simply by looking at me. It's the idea that when we conflate weight and health, we are typically just focusing on weight, and that doesn't tell us anything about people's health behaviors, right? It doesn't tell us what they're eating, whether they're exercising, how much they're exercising, etc. We make a lot of assumptions that people in larger bodies eat junk food, that they don't exercise, that they're lazy, they don't care about their health. And you know, there are some fat people like that, and there are also some thin people like that, and you can't really tell the difference by looking at us. So then for the last bit of this, I wanted to just take you through some of the science behind this concept called health at every size, which, you know, some people have denigrated this concept by saying you can't be healthy at every size, which is not actually what health at every size means. What it means is that no matter what your size, no matter what your physical status, you have the ability to pursue health in some way if you choose to. You have the ability to engage in positive health behaviors. And it's been about 20 years since we actually started studying this, and the findings are really interesting. So starting with, and I don't have any time in front of me, so I don't know how close I am to the end. So someone want to like holler what the time is?
You have about 20 minutes. Or
Okay.
just kidding, you have about 10 minutes. It's 6:07.
Okay, great. So I'll quickly run through these. Bacon 2002, you know, looked at white women. A lot of these studies kind of compared like a control group that was typically given like straight diet, you know, nutritional and physical activity interventions, the kind that we're all familiar with, versus a group that was, you know, given like health at every size, which was, in this case, it was weekly sessions, it was body acceptance, you know, information on nutrition, eating behavior, it was social support. And she found, like so many of these studies find, that like, you know, first of all, you lose huge numbers of people in the diet group, right? 41% of the people dropped out. So right from the start, you know, that kind of makes me wonder about that finding. 8% dropped out of the Hayes protocol. The diet group lost weight at first. Both groups improved their sort of biomarkers. The Hayes group did more physical activity. The dieters did less physical activity, which, you know, makes sense. I could understand that. She followed up on that study a couple years later, you know, because again, a lot of the research on weight and health only goes for a very short time, typically no more than 2 years. You know, what happens after that? Well, she wanted to look at that. So what she found is that the Hayes group had maintained their weight. They hadn't lost weight, but they hadn't gained it. They lowered a lot of those risk factor, you know, biomarkers. The dieters had higher weight dissatisfaction, which we know can actually lead to poorer health outcomes. And the Hayes group had lower weight dissatisfaction. So, you know, I would say that at the very least, these are comparable and probably much more than that. Soda in 2007 was looking at a protocol that was called something a little different. It was eating competence, which was actually a term created by Ellen Satter, a dietitian. But it's very similar to like intuitive eating and health at every size. And again, found that the more eating competence you had, in other words, the less dieting behaviors, you know, lower the blood pressure, triglycerides, and overall cardiovascular risk factors. So, I mean, I guess I don't need to run you through all of these, but the bottom line is that they pretty much all found, you know, strong scientific evidence that coming at health from a weight neutral perspective actually has a lot of scientific basis and, you know, in some cases, in most cases, better results than coming at it from the more traditional diet and exercise perspective. So yeah. The last slide I want to show you, and then we'll have time for questions if we should have any. I wanted to leave you with these images from the Big Moves Dance Company, which is a dance company in California from the Bay Area. And it's a company dedicated to, as it says, promoting size diversity in the world of dance, making sure everybody can dance. That doesn't mean bigger bodies are better or bigger bodies are worse. It basically means, fat people can dance too. And that is truly what fat liberation is all about, right? It's the idea that fat people are entitled to live meaningful lives, free from oppression, free to do what they choose, just as all humans are, right? So it's really that simple. Thank you, and I will stop sharing my screen and we can do questions if there should be any. All right.
Great. Thank you so much. We had a lot of activity in the chat, but we're actually going to take one of the first question written, and then we can do you can raise your hands after that. So the first question, which I'll also put in the chat, is when existing in a fat body, whether by material reality or personal perception, how, if at all, can one pursue specific goals related to body size, aesthetic, and or weight without contributing to the objection of fat bodies at large?
Interesting question. First of all, I would say that I believe, and I think most people who might say they believed in fat liberation believe in what one person has labeled the underpants rule, which is basically like, your body, your underpants, you do what you want with them. Nobody gets to tell you what to do with them. So I really believe that in everyone's bodily autonomy and, making the choices that are right for them. We live in a culture where this is so deeply ingrained that most of us don't actually even know how biased we are against fatness and fat bodies. So yes, it's true that making certain choices for yourself, might bump up against some of those principles in ways that seem irreconcilable, if I'm reading the question, if I'm understanding the question correctly. And it is very hard, sometimes impossible, to resolve those discrepancies and those conflicts. And I think that that's where fat liberation would say, look to the systems of oppression rather than the individual choices that people make, right? So if we, and that each of us will resolve those things in the way that feels right to us, in the way that feels like it's not, like making things worse for fatter people. So if we look to, education, if we look to medicine, if we look to the media, if we look to make changes in those ways, I think that's probably the most constructive way to go. And I'm sorry if I didn't understand the question correctly.
Thank you. And I think now, I know, like I said, there's a lot of questions in the chat, but if anybody wants to come off mute or raise your hand, then we'll call on you. I don't see any raised hands, but so I'm going to go to the next question that we have, which is how do we go about addressing fat phobia in the medical field when dietitians and nutritionists have come to the conclusion that weight is not a causal factor for health? How do we bridge this bias in medical providers who have extreme power in facilitating access to quality care?
That's the $64 million question, isn't it? And I've come to believe that it's through efforts like these, which is why I'm currently involved in a project to write curricula for medical students and for nursing students and for dietitian students, because, I think that a lot of what people learn in their graduate schooling, their professional schooling, becomes sort of codified in their minds as the way things are. So I think that, obviously we all live in this culture, and this culture is deeply fat phobic, and we're all human beings, so we're all going to take part in that. But if we can make sure that there are some of the science is actually conveyed, and that some of these biases are challenged in medical school, in professional schools, I think that's the best way to go about it, because I know that once you're out in the world and you're practicing, what you think just becomes more deeply ingrained and, confirmation bias leads you to sort of dig that in even deeper, and it becomes very hard. And I understand that. It becomes very hard to change your mind. So I think it's got to start with education. Easier said than done.
And I know that there was a kind of a piggyback. So you mentioned this piece of science. Would you say that's also a way to, in two different scenarios, how do you communicate this to family members? And then specifically, how would you communicate this to a physician if you're a patient?
Oh, let's start with the second half of that, because that's something I've had to do myself on a number of occasions. So, like most people, I've had good doctors and I've had less good doctors, and I believe they're all trying to do the best they can, and that they all have my, health ultimately in mind. I have written letters to doctors. I have talked with doctors. I have given them books to read, and I have fired doctors. That's pretty much, I can't change someone's mind. All I can do is say, maybe you want to consider this. And I've had people be very open to that and be willing to engage in a conversation. And honestly, as a patient, that's all I want. I want a conversation. I don't want someone just, well, I'll give you an example. My husband, who's a thin person, he's not a fat person. He's weighed the same thing that he's weighed since he was 21, and he's like, whatever, BMI 23. He's like, he developed high blood pressure. He went to the doctor. And the first thing the doctor said to him was lose weight. And then the doctor kind of caught himself and said, oh, I guess you don't have to lose weight. As a thin person, he could say to him, that's bullshit. I don't need to lose weight. But, if someone said that to me, that's a very different thing. And I'm going to feel shame, and I'm going to like creep out of the office, and I'm going to be crying, and I'm going to just, So I have found that trying to educate my doctors, and then if I have the privilege of being able to walk away from a practice that's not serving me, then I do that. Family members is really tough. I mean, I've been teaching this stuff for about 10 years, and I would say that it takes a willingness, and it takes a lot of time to process and discuss this kind of thing before you can even begin to shift the way you see it. So, again, I guess here, Mom, here's a book. I'd really like it if you read, and then it would be great if we could talk about it. If someone is open to that kind of thing. Sometimes they are and sometimes they aren't, but I know that these are, because my students will say, I went home over spring break and I talked to my family about this, and they, either they listened and it was really great and we had this great conversation, or they told me I was full of it. So, that's a tough one for sure.
Thank you. And I saw that there was a couple of comments in the chat regarding this specific question, so I'm going to bump it up in terms of just the order. I find myself struggling with using the word fat because of the past weaponizing of the word to dehumanize people outside of BMI standards. What could I use instead? And I recognize that there are a couple of options in the chat, but just to hear from you, Harriet.
Yeah, and I say I totally understand why people might have I had trouble with that word for a long time too. Some of the words that I have heard people use are things like, living in a larger body, or, larger size person, or, language is so individual. So, and it just is going to depend what you bring to it. I think it's probably good to avoid words like overweight and obese, just because those are part of that medicalization, and they sort of imply that stigmatization. But, larger size, heavier, try some things out and see what works for you, honestly. And you might be able to use the word fat over time. That certainly happened for me.
I just want to give the opportunity again, if anybody wants to come off mute or raise your hand to ask a question. We have 10 more minutes. And Sandra, I do see your question in the chat. If you want to come off mute and say it again, or I can also read it, whichever is fine. So we have As a public health practitioner, how can we promote healthy lifestyles, eating, exercise to children leading into adulthood, such as the graphic you showed earlier in the slides, without shaming them, without shaming or putting the strain on the children?
Great question. And I think that number one is to do it outside of the context of weight. You know, many of the public health messages basically always get wrapped around weight, right? So it's not that you should not drink soda and drink water because it's better for you. I mean, that can be part of the wording, but the big reason, the reason everybody knows, is because soda makes you fatter. And how that is conveyed on a number of levels. How do we measure success? We talk about weight loss in kids, rather than, gee, I feel better when I don't drink like 64 ounces of Coke every day. So finding other ways to talk about health, leave weight out of it. You're not going to control weight. Bringing it into the equation at all simply because we have such a strong culture of thin is better. I think any mention of it just immediately reinforces that. So physical activity, the purpose of physical activity is not to burn off the calories you've eaten, which is what my daughters were taught in middle school in health classes. It's because it's good for your body and it feels good, about looking for ways to move your body that feel good to you, that make you feel joyful, rather than ticking off a box and burning off calories. So, it's simply look for ways to talk about these things that don't involve weight. And I think you'll find, number one, how much of what we say does get wrapped around weight. And number two, that you get to the real stuff when you leave weight out. You get to the real measures and descriptions of health that way. But great question. Thank you.
And I see 2 raised hands in the chat. Lumbe, I hope I'm saying your name right. I think you were first, so let's go with you first, and then we can go to Lori.
You should be able to unmute now.
Thank you. I really appreciate your talk, and it's slightly triggering because I was part of a pre-diabetes program at my agency, which should be on the leading edge of what you talked about tonight, and it's not.
Mm-hmm.
And we were weighed every week as a part of the pre-diabetes program, and I wasn't losing weight. I have an underactive thyroid and some other autoimmune condition that really hindered me, but my lipid levels had gone down. My A1C went down 4 points, but all my health coach could focus on was the fact that I lost maybe 2 pounds over a year. And I'm like, but my numbers are amazing and my doctor loves me. I'm now exercising like 200 minutes a week.
Mm-hmm.
And I just never got affirmed for that. And I just want to say thank you so much for emphasizing that we just want to feel good and we want to have good numbers beyond the scale, what the scale says. Thank you.
Oh, you're welcome. That makes me so sad actually to hear that, because what a missed opportunity, right? For someone who's supposedly there to support your health. They totally missed the opportunity to reinforce that. I mean, that just makes me really sad. And I'm glad you came tonight, and I'm glad this is somewhat affirming.
And Lori, we can go ahead and go to you. You can go ahead and unmute. We see you're unmuted, but we can't hear you.
We still can't hear you.
Lori, if you want to type it in the chat, I can come back to you in the meantime to see if your audio is working. So I'll take one from the chat while we're waiting to see if Lori can come on, but how have the dynamics of fat liberation changed throughout history? Where do we currently stand in terms of the use of BMI in medicine and public health, and how can we address issues, controversies, myths associated with anti-fatness and empower folks to love their bodies? It's a two-part question.
Yes, that's a huge question. That's a really great question. But I mean, unfortunately, I think that like to just pick a chunk of it, BMI is still very much the measure of fatness and therefore health in medicine. So I would love to see, that's why I do talks like this. I would love to see, and why I'm working on this curricula, I would love to see, medical schools addressing this in some way, at the very least exposing doctors in training to these ideas, right? I mean, so many doctors I've talked with and dealt with over the years just seem absolutely like they've never heard of this, which I don't know how they got, I don't know how that is possible, but, so I think that we are, and as someone in the chat mentioned Sabrina String's book, which I think is a hugely important book, right? Fearing the Black Body, highly recommend it. And because another piece of this is that our cultural ideals of thinness are also cultural ideals of whiteness. So it's really hard to talk about weight stigma without also talking about racism. And you can see where we're at with that right now, right? We've made bitty bits of progress, but there's a lot that still needs to happen. So, golly, I wish I had an answer to all of those questions, but I don't. I'm sorry. But I do think that thinking about these things intersectionally is got to be part of the process we have to engage in.
Thank you. And Lori, we have 3 minutes. I do want to give you the opportunity, if you're able to have your mic on, if it works. I just want to make sure that we get to you. Okay. So I see in the chat, in a nursing class we did, the implicit bias test, one part was about fat bias, and my score indicated that I had lots of anti-bias, but really, I know I felt sorry for fat people, one of which is me.
Okay, and that makes sense to me, right? I actually have my students do that test too, and here's what I tell them, which I totally believe. What that test measures is how well you have learned the lessons society has taught you about fatness. It's really not about your personal feelings towards specific fat people, but it's really how well have you learned, internalized those lessons that we start to learn really from birth, that so many parts of our culture come together to teach us over and over and in many, many ways, that, it's bad to be fat, it's better to be thin. So, getting a score that's like, you are, very biased against fat people just means you've done a good job being socialized, and that unfortunately now you're going to have to work hard to sort of unsocialize yourself, but it can be done, and becoming aware of it is the first step. So kudos to you for, thinking about it and addressing it on this level.
Thank you, Harriet. I'm gonna do one last question because we have 1 minute and you do not have to answer this directly, but Valerie's asking, would you be willing to share your contact information to speak with some medical students about how we can make changes in our own curriculum? And I did see in the chat that there was some collaboration going as to how that can come about.
Yes, very much so. And in fact, if there's anyone in this chat who's interested in being part of that project that I described, I just put my email in the chat, and I would be super happy to connect with anyone here to talk about that or anything else.
Thank you. And we'll share this on Blackboard as well. And Harriet, that's really all of our time. Thank you so much. That was very eye-opening, and we're just so grateful to have had you tonight.
I think this class is phenomenal. You guys are lucky to be able to take it, and thank you for having me.
Thank you. Everyone have a good evening, and we'll see everybody, the students in the other class. Thanks.
Bye-bye.